Before Manoj talks about specifically the approach we're going to take within the Go-Kart project, I wanted to give you an overview of the sort of patient-oriented research that we're suggesting might be a useful approach to take. And this is specifically about studying patient preferences and barriers and enablers to actually participating in an early phase clinical trial. So understanding what might stop or help people to actually participate in a trial. And studying that so that we can learn not only for the purposes of the particular trial that we're planning, but also so that other teams can benefit from that knowledge. So I'm going to quickly cover why and how we might want to explore patient preferences in the context of participating in an early phase clinical trial. Again, I suspect preaching to the choir a little bit on that. I'll try to convince you that one approach that we can take to that is to actually think about this as a behavior issue, as a behavior change issue, both from the perspective of participating, so patients participating in a clinical trial is a behavior they need to conduct, and recruiting is something that health professionals have to do. And by framing it in that way, we can start to understand barriers and enablers in a more strategic way. And I'll talk about that. So why might we want to explore patient preferences and barriers and enablers to early phase clinical trial participation? So from the research side of things, and ultimately from an impact perspective, we know that recruitment rates to clinical trials in general are quite low, in some cases below 5%. And that has implications for, we have these fantastic new therapies coming through from the bench that can't even be evaluated because there's limited power to detect differences. And there's concerns of, even if we are able to recruit to these trials, the participants may not be representative of the samples for the next phases and ultimately those that we want to take on board the therapies down the line. So there's a recruitment issue. And there's also some literature on this. So Fater, about a decade ago, did a systematic review just to understand what do we know about what people are saying about what stops them or helps them from participating in trials. So we know that one thing that stops them is that because of the nature of randomization, sometimes people prefer the treatment versus the control. Makes sense. Uncertainties about the trial, worries about side effects, about outcomes, about tests involved. There's also social influences involved, so the health professional team, family members, and social groups obviously have an impact on whether people decide to participate. There's practical issues that are coming through, obvious ones around commuting, working, childcare, time, financial burden are all barriers to participating in trials. But there's the facilitator side, and we've talked a little bit about this already, that some people express a sort of altruistic perspective on wanting to contribute to medicine specifically and benefiting others, wanting the latest and best treatments if they're available, having a greater chance of a cure, and having closer monitoring are all things that are coming through from what patients are saying, whether or not they can achieve that within an early phase trial or not. But it's not clear how comprehensive that approach, these approaches have been in the past. So one of the findings from this review is that many studies ask for only what is your top barrier, or they asked physicians to report on what patients' barriers are, which is clearly not the best way to do it. And so we're interested in speaking to patients specifically that may be eligible for an early phase trial to get from their perspective what are the barriers and enablers to them participating. Because if you think, so some further issues around patient preferences here, as from the research side of things, research teams, clinical trial teams, they live and breathe clinical trials. They know the jargon, the processes, the measures, the treatment, the rooms, the setting. We've talked a little bit about this already. But all of this may be new to the patients that might be recruited to an early phase clinical trial. They might not know the ins and outs. What does even a clinical trial entail? They might have competing demands on their time. And you'll know this, that being in hospital is not a normal situation. It's an emotionally charged state. You're dealing with challenging, life-threatening events, and that's clearly going to affect the decision-making process for deciding to participate in an early phase trial. So we feel strongly that we need a better understanding of those realities from the perspective of the patients who ultimately could be recruited to an early phase trial, so that we can ensure that our recruitment processes take those realities into account. We're also interested in the realities of the healthcare team, physicians' preferences and barriers and enablers in terms of recruitment, so that we can flag any potential issues that we might not have considered. So for example, who specifically is speaking to patients in order to inform them about the trial and to recruit them? And how does that relate to what patients prefer? who patients prefer to speak to make a decision about whether to enroll or not. There's lots of logistical steps that we might not be thinking about. Clinicians need to fit recruitment alongside competing demands and other clinical trials that might be going on. And we know some of this from the literature as well, but it's unclear how comprehensive that is and to what extent that's been addressed within early phase trials. So we're interested in taking a patient-oriented approach to designing an early phase clinical trial protocol that really takes into explicit account the perspectives and realities of patients and healthcare providers to inform that from the start for the trial. So the rationale here is if we take a patient-oriented approach, we can ensure that we promote that our trial protocol tries to leverage as much as possible enablers and reduce any barriers to make it easier for anyone who might want to participate, to reduce any of the barriers to them participating. So the approach the broad approach that we're proposing, and Manoj will go into this in a bit more detail, is a multi-stakeholder mixed method approach. So what that basically means is we're interested in speaking to patients about participating in an early phase trial and speaking to clinicians about recruiting to the trial and providing ongoing care. And for each of these two stakeholder groups, we're interested in speaking to them directly, so doing interviews with a small number of patients that might meet inclusion criteria for the ultimate trial, and a small number of clinicians that would be involved in recruiting and providing care, to really get in depth in the interviews, but also getting a representative sample, so doing a survey of these same two groups across Canada of patients with a clinical condition and healthcare professionals that would ultimately be involved in recruitment. So we're getting a mixed method in terms of qualitative interviews and surveys alongside, all with the purpose of taking these findings, triangulating them to directly inform what we propose to do in the clinical trial protocol. So our questions are, what might help or stop people from participating in an early phase trial in general, and in this case will be with respect to CAR-T. What might help us stop clinicians from recruiting? So some of the reasons will be obvious to everyone, but some of the reasons might be less so, and it's worth trying to highlight those in a more explicit way. And it comes back to that idea that whether it's participating from a patient perspective or recruiting from a clinician's perspective, these are things that they need to do, in other words, behaviors. And so my background is in behavioral science and behavior change, which I guess makes sense why I suggest that approach, but the advantage of framing it in this way is we know from decades of research from behavioral science about the factors that determine and the barriers and enablers to what stops and helps people from doing things, doing behaviors. And we can apply those decades of that evidence base to a new setting, in this case, participating and recruiting to early phase clinical trials. So with that in mind, how do we actually do that? How do we systematically assess barriers and enablers? So one approach, and the approach that we're proposing, is to draw on this framework, which is called the Theoretical Domains Framework, which was led by a team in London in the UK. What they did was they realized that the field of behavioral science is massive. There's lots and lots of jargon, almost impenetrable in some cases, but there's insights that people need to draw from that literature. And so what they did is they brought together the key ideas, the key theories and evidence around what works to understand behavior and behavior change. They synthesized 33 theories and 128 factors down to 12 specific domains covering the range of different things that relate to whether people change their behavior. So they did that in 2005. They validated that approach in 2012. So this framework includes 14 domains, and I'll show it to you in the next slide. And people have used this quite a bit. Researchers have used this a lot to try to more systematically understand barriers and enablers from the perspective of patients and health professionals in a range of settings, but never, to our knowledge, with respect to specifically understanding participation and recruiting to early phase trials. So real, I think, innovative approach to approaching this. So the advantage also is there are topic guides or interview schedules for actually doing this that are available that can inform what you say, what you ask in the interviews, and questionnaires that can be used for surveys. The idea here is to try to be more comprehensive to assess barriers and enablers. So if we think about interviews or focus groups or surveys, we might have some ideas about what we might want to ask, which will be fantastic, but there may be things that we miss. And using a framework based on pre-existing evidence will help us to cover the breadth of factors that we might not think about. So what I mean by that, and if I show you the list of factors here, so things like this is a list of, think of this as a list of factors or issues that determine whether or not we do any behavior. So whether we have the knowledge about the behavior, whether we have the skills to do it, whether we feel we can do it, are we optimistic, is it part of our identity, do we have beliefs about what do we think will happen in terms of risks and benefits, is there some sort of reinforcement, are we motivated, is it part of our broader goals and does it compete against other things that are important to us, might we forget to do it, can we pay attention to it, are we weighing pros and cons, what's the environmental context around that, do we have the resources to do the behavior, who in our social environment has an influence on our decision making, and how do we feel about it from an emotional perspective. And one that's fallen off at the end is, if we are motivated and we want to do it, how do we make sure that we follow through on that? And so if we think about that from, so that's basically what I just said. So what I thought I'd do is that's quite abstract, I suspect. So what I thought I'd do is walk you through some work that we did, not from the perspective of participation in a trial, but using this framework to understand barriers and enablers from patients' perspectives with respect to understanding what might stop them from adhering or taking their medication post-MI. So we used that theoretical domains framework to speak to patients, to really get into depth about what stops them or what might help them to take their medication. And that helped us to develop the content of a trial that's currently running across Ontario. So the issue here, to situate ourselves clinically, and this is again thinking about where I spend most of my time in that sort of second valley, to situate yourself. So this is coronary heart disease, which we know is the leading cause of death, is a leading cause of death, accounting for 1/3 of death in people over 35. But we also know that if people take medication, they can reduce their risk, their mortality risk, by up to 75% if they take 4 specific types of meds. We also know from other research that between 1/3 and half of prescribed medication isn't taken as directed, and there's tons of trials to try to understand, or that jump to solutions first, to say we think we know what might help people to increase their medication, taking their medication. And so across those 182 trials and a Cochrane review of them, they basically found that there's a lack of reliable, effective interventions to address medication adherence and helping people. So we sort of said, well, let's sort of go back to the drawing board to some extent and really understand and speak to patients about what are the issues here that are barriers and enablers to taking medication, at least in this population. So we did a relatively small, though from qualitative standards is the sort of sample that you might expect. So 24 interviews with people post-MI. It ended up being mainly men, mainly in their early 60s. And I can go on about this for hours if you like, but I won't do that. Instead, I'll summarize the findings. So we used that framework that I mentioned to really drill that. We asked questions about each element of that framework, and what we found that came through as the key elements were that there were issues around beliefs about consequences. So on the positive side, I'm certain my medication will keep my heart healthy, but obviously I'm concerned about side effects, so that's straightforward. You would expect that. Memory issues, I sometimes forget. I find that reminders can help me. Behavioral regulation, I use a pill organizer, created a routine. Social influences, I take my medication because my healthcare provider recommends it and my family encourages me to take it. So I think up to that point, you probably agree that that's fairly commonsensual. You would expect that. I think what the interesting additional element was what came through is this issue of identity, that a lot of people said that taking their medication didn't fit with who they saw as a person, how they saw themselves as a person. So I don't see myself as a person that takes medication, and that's the reason why I don't take my medication. So the identity component is something that we don't naturally jump to when we think about medication adherence, and that may or may not resonate with you yourself if you do take medication, but it did come through with some of our participants. So it's really to highlight that using a framework, a broad framework like the theoretical domains framework, allows us to go beyond the obvious things. It allows us to capture the obvious things, but also start to get at some of the things that might be a little less obvious. And we're hoping to get at some of that with the CAR-T work that Manoj will talk about. And this is just to highlight that we also did some additional survey work with a larger sample, more representative, to actually see whether some of those factors predicted people's motivation to take their medication, actual medication adherence. Short answer is we were able to quantitatively show that the more confident people were, the more outcome expectations they had, the more they motivated they were to take it, but it was actually social support, having a specific plan and being confident to actually determine whether they took their medication. So, yes?
Can I ask a question about where social determinants of health fit in? Is it in social supports or?
So it could be. Yeah, that's a great question. So within the way that we measured social support would capture, so these factors are closer to the behavior than the broader context of the social determinants. And so the idea behind these frameworks is they're meant to represent the easier to modify components that determine behavior, but not that we expect that the social determinants will influence, rather than going back to the social determinants and trying to change those. So it's more proximal, closer to the behavior rather than the broader context. So recognizing that obviously the social determinants are a clear determinant of behavior, but for a research team trying to affect change in taking medication, change in the social determinants is a more challenging process than addressing the proximal things. So we start with the low-hanging fruit to see if we can help with that and work our way back. At least that's my approach. So last slide. So we feel that studying barriers and enablers to early phase trial participation can help us to really get a better understanding of patients' and physicians' views about being involved in early phase clinical trials, and doing this before we actually design the trial protocol, so that we bring in some of these views. And that we can make patient-oriented adaptations to things like the information sheet, the recruitment procedures, the trial participation in collaboration with our actual patient partners, and that key insights that ultimately what we're trying to do here is what we feel is go-kart, which Manoj will describe, is probably the first comprehensive mixed methods behavioral theory informed investigation of early phase trial participation and recruitment. So we're trying to basically do our homework in a comprehensive way to understand what might stop or what might help patients and healthcare professionals engage in this early phase clinical trial, so that we can get answers that can ultimately move forward to further phase trials. So I'll leave it at that. Manoj is going to pick up from where I left off, I think, just to acknowledge the giants whose shoulders I stand on, really, and the funders for that. And I've got some references to the, if at all of interest, there's a lot of literature on this theoretical domains framework. If you're doing focus groups or you're doing interviews with people, it provides some examples of questions you might want to ask in case that might be of interest to you. That's there, and I'm happy to be contacted later if that's of any interest.